So thank you for the invitation. For speaking about difficult vascular access, it's a big subject, so I'd like to continue this discussion of access this afternoon by talking about the difficult situation where the patient has lost one or both of their central veins. This is a difficult problem, and the step 1 in management is prevention. Step 2 in management is prevention. Step 3 in management, you may have guessed it, is prevention. What I mean by that is that we need to reduce the time patients have central venous catheters unless that's a definitive access. If we can protect the central veins, then we can maximise upper limb options, and then by introducing into our practice all the things to a little or greater degree have been shown to prolong access patency, then we can set up a virtuous circle and reduce this problem. That said, there will be times when we have to deal with central vein occlusions. So the first step is to say, okay, well, does that patient still need hemodialysis? Can we move on to peritoneal dialysis? If that's not the case, then there are really two strategies. Can we try and restore some flow through the central veins, or do we give up on the upper limbs for the time being and try and find some access elsewhere, typically the lower limbs? Regarding the lower limbs, although the great saphenous vein is the go-to vein for vascular surgeons, as a way of making access in most people's hands, it's not great. So if we're looking for an autogenous access in the lower limb, then we use the superficial femoral vein. And just like the basilic vein, it can be transposed. So it can be mobilized right down to the knee, down to the gastrocnemius muscle with division of adductor magnus tendon, and then it can be tunneled superficially, anastomosed to the distal femoral artery. It's often a big vein, so taper that distal anastomosis and you'll reduce the Jacks of steel, which remains a significant problem with this access. It's a big operation, it's a big wound to heal, so maybe it's better in the younger, fitter patients. The alternative strategy is to put in a lower limb a thigh loop graft, and there are various orientations of which this could be used. My personal preference and my personal practice is to use a mid-thigh loop. That keeps the incision out of the groin and is perhaps a little bit more dignified for needling. My tip is to use a cuffed graft if that's available, and to keep that venous limb as parallel to the vein as you can get it. It's a synthetic graft, so infection rates are higher than with a femoral vein, but steel is less. If those options are not acceptable to the patient, or the vessels aren't appropriate, then we've got to look to restore central vein flow. As we've heard, the initial way to do this is probably with wires, stents, balloons, stent grafts, but recurrent stenosis rates are high. If you may be able to bypass around or across a central vein stenosis, there may be a patent central vein that's available ipsilaterally, or perhaps taking that graft across to the contralateral side. If that's not possible, in my practice now, we've gone to using the hero and superhero grafts. The hero graft's been available to us for about 10 years. The original hero graft consisted of a sort of standard wall PTFE graft fused to a titanium connector. That's then used to attach it to the central vein portion, which is a nitinol reinforced silicon tube, and that's manipulated through the central vein disease into the right atrium. The superhero part of the system the modification involves the use of an early puncture graft, which is then connected to the outflow portion with a titanium connector. The hardest bit of this procedure is getting the wire through the venous disease into the right atrium, and some quite advanced endovascular techniques might be needed for that. Once you've got a wire through, you dilate the channel a little bit, just enough to get the outflow component through a 𝗘𝗴𝗆 sheath. The arm graft is put in the standard way, and the two are linked together in an incision in the delta pectoral groove. And it should look something like that at the end. How do these two strategies compare? Hero graft versus lower limb graft. There's no randomized trial, but this study showed that there was no difference in patency rates or infection rates, but with the hero graft, there was twice as many interventions were required to keep them working. Now, if those two strategies are not possible, or fail or run out of options, then you're looking to remap all the vessels in the body and saying, is there an artery, is there a vein that we can link with a long PTFE graft? Failing that, can we get a wire and can we get a catheter into the cava, either directly translumbar or through the kidney or through the liver? These are all possible, but if you need to do this, and they do work, but if you're using them, expect complications, expect to need to do frequent re-interventions. And I think with adequate prevention, use of the lower limb and the superhero graft in our practice, the number of patients that need these desperate measures should be kept to a minimum. So in summary, optimal care, although that's difficult, should limit the need for complex access. If you do have these difficult patients, then reassess them, and you need to choose the least worst option for this patient. And in our practice, in terms of the number of procedures that we're doing, it's a central vein treatment that leads. We then use a superhero graft next, and then a steady trickle of lower limb grafts. Thank you very much.
Thank you very much. We are going only to the most expensive total endovascular solution for AV access formation.
I've got 2 minutes spare. Okay. No, go down.
Oh, there's no
Oh,
problem.
yeah.
Okay. All right.
An extra 30 seconds we have. So I've got an extra 2 minutes because I finished early. Right. So I think it's interesting to reflect that the basic technique for creating a surgical fistula hasn't really changed since it was first described in the 1960s. And with a surgical fistula, we attach an artery to a vein and we divert all the flow into that vein. But within the last few years, there are now devices that allow an anastomosis to be formed between the radial artery or the ulnar artery deep within the proximal forearm and its adjacent vein. So flow goes up through a perforator into either the bacillic system, the cephalic system, or both. There are 2 devices that are able to do this now. There's the WaveLink and the Ellipsis. The WaveLink system consists of 2 full French catheters. The arterial one is positioned in the proximal radial artery or the proximal ulnar artery, and the other one into the adjacent vein. They've got powerful magnets on the catheter which essentially cause the catheters to stick together, and that orientates the electrode. They can be inserted in the wrist and pass proximally, or into the brachial vessels and pass distally. And once positioned, the radiofrequency probe or radiofrequency pulse is fired. That cuts and seals an anastomosis and creates the fistula. And this is all done under radiological guidance, and only small volumes of contrast are needed. As you might imagine, planning is key to this, and with regard to the WaveLink system, you're looking at it needing a cephalic vein or a bacillic vein that's 2.5 millimeters or more. Where the fistula is created, the radial or ulnar arteries in the adjacent veins need to be at least 2 millimeters in diameter, and those veins need to connect to a 2 millimeter or more non-tortuous perforator, which then connects to either the cephalic veins, bacillic veins, or to both. The Ellipsis system, planning very similar, but this is all done under ultrasound guidance. So a needle is passed into a vein on the antecubital fossa. It's then gently guided down the perforator, and the proximal radial artery is cannulated. The 6 French Ellipsis system is then inserted, and then through a combination of pressure and heat, the anastomosis is formed. Most people now gently dilate it, and the fistula is created. Both of these systems create the fistula in the proximal forearm. So flow can be into the cephalic system, into the bacillic system, or both. This patient has very prominent veins, but typically the veins are not as prominent as with a surgical fistula. The thrill is less, brew is less. And therefore, the cannulation site needs to be carefully planned. So you need to do an ultrasound post-creation to work out which veins are carrying most of the flow. Because it might be you put 2 needles in the cephalic vein, it might be 2 needles in the bacillic vein, or it might be 1 in each. So how does it work? If you take all the patients coming for an assessment for an upper limb access, then about 30% of them are suitable for endo AVF, although the estimates do vary. Of those who are suitable for a surgical AVF, then about 60% of those are suitable for an endo AVF. Technical success rates are quoted to be very high. Maturation rates very high, although some of the definitions for maturation I think are quite generous. I think that reflects that 2-needle dialysis is possible in about 60 to 95% of patients. Reintervention rates vary enormously. They tend to be embolizations, typically of the brachial veins that divert flow up the perforator superficially, balloon angioplasties of stenosis near the perforator at the anastomosis, and surgical superficializations, typically of the basidic vein. Patency rates are as you see them there, but we're thinking, well, how does an endo AVF compare to a surgical AVF? There's no randomized data yet, probably never will be. This meta-analysis came out this year and found there was no difference in the time to 2-needle cannulation, nor the secondary patency rates between endo and surgical AVFs. But there was a benefit with endo AVF at needing less future interventions. So, how does it fit within our sort of current access ladder? I think it should come in. I think it's being used after a forearm fistula because it doesn't preclude the use of or the creation of a brachiocephalic fistula or a BVT fistula in the future if that's required to keep that access working. So in summary, it's a promising new technology. I think they're encouraging results, but it's eye-wateringly expensive. And I think it's still finding a place in the treatment algorithms in many centres. Thank you very much.